This video reviews the paper Hydrocephalus in cerebral venous thrombosis by Zuabier and colleagues, published in the Journal of Neurology in 2015. The central question is clinically practical. When a patient with cerebral venous thrombosis develops enlarged ventricles, is hydrocephalus itself the target, or is it a sign of a deeper venous process? The article argues for the second interpretation in most cases. Hydrocephalus was uncommon overall, but when present it clustered with deep cerebral venous thrombosis and edema in the thalami or basal ganglia. That pattern changes how we read the scan and how we think about management. Raised intracranial pressure is a familiar feature of cerebral venous thrombosis, but raised pressure does not automatically mean hydrocephalus. Previous series reported hydrocephalus in only a small fraction of patients, roughly 0.2 to 6.6%, and many estimates were not based on systematic re-review of imaging. Zuabier and colleagues therefore treated hydrocephalus as a specific radiological question. How often is it really seen? Which venous territories are involved? Does it predict poor outcome? And most importantly, should it lead clinicians toward ventricular drainage or shunting, or toward more aggressive treatment of the venous thrombosis and intracranial pressure itself? The study used a consecutive cohort of patients with cerebral venous thrombosis, aged 12 years or older, seen between 2000 and 2010. Diagnosis was confirmed by venous imaging, angiography, or autopsy. A key strength was central re-review of neuroimaging by two neuroradiologists. Hydrocephalus was not just a casual impression. It was defined by either a bicaudate index above the age-adjusted 95th percentile or a radial width of the temporal horn of at least 5 millimeters. This matters because the paper ultimately shows that temporal horn enlargement was much more sensitive than global ventricular enlargement. Outcome was assessed with the modified Rankin scale at follow-up. In the cohort, 99 patients had cerebral venous thrombosis. 20% had hydrocephalus on imaging, but after excluding cases where hydrocephalus was explained by other conditions, 14 true cerebral venous thrombosis-associated cases remained for detailed analysis. Most were already visible at baseline imaging. The important imaging phenotype was striking. Temporal horn widening was present in 93%, while a high bicaudate index was present in only 14%. In other words, if clinicians look only for global ventriculomegaly, they may miss the pattern that this paper considered most relevant. The radiological signature pointed away from a diffuse cerebrospinal fluid absorption problem and toward deep venous disease. Deep cerebral venous thrombosis was present in 64% of patients with hydrocephalus, compared with 9% of those without hydrocephalus. Edema in the basal ganglia or thalami showed a similar split, 64% versus 4%. Straight sinus thrombosis was also more common. The recurring pattern was not simply bigger ventricles. It was temporal horn enlargement in the setting of deep cerebral venous thrombosis and swelling around the deep gray structures. The proposed mechanism is localized obstruction near the foramen of Monro. Deep venous thrombosis can cause edema or hemorrhagic infarction in the thalami and basal ganglia. That swelling can narrow the third ventricle or the foramina of Monro, limiting cerebrospinal fluid flow from the lateral ventricles. The resulting hydrocephalus is therefore interpreted as obstructive and edema-driven. The authors contrast this with the classic idea that venous sinus thrombosis raises pressure by impairing cerebrospinal fluid absorption at the arachnoid villi. That mechanism may explain intracranial hypertension, but it does not fit the localized temporal horn phenotype as well. Patients with hydrocephalus looked sicker. Good outcome was less common, 36% compared with 68% in those without hydrocephalus, and mortality was higher, 29% compared with 9%. But after adjustment, hydrocephalus itself was not an independent predictor of outcome. The interpretation is important. The ventricle is usually a marker of severe deep venous disease, not necessarily the primary therapeutic target. Most patients received therapeutic heparin. Some needed thrombolysis or decompressive surgery. Only one external ventricular drain was placed before the diagnosis of cerebral venous thrombosis. The article does not support routine shunting for this phenotype. The take-home message is pragmatic. In deep cerebral venous thrombosis, actively look for temporal horn enlargement. Do not rely only on the bicaudate index or on obvious global ventriculomegaly. When hydrocephalus is present, treat the venous thrombosis and raised intracranial pressure carefully, and reserve cerebrospinal fluid diversion for selected situations rather than using routine shunting. The authors also note important limitations. The study came from a tertiary referral center, the case mix was severe, retrospective and prospective data were combined, MRI availability was limited, and the temporal horn cutoff was internally derived. Even with those caveats, the paper makes a useful point. Cerebral venous thrombosis-associated hydrocephalus is real, recognizable, and usually edema-driven.